Welcome back to another episode of What Did the Patient Say with Doctors Dana and Lauren Brindisi, sisters and owners of Carolina Functional Neurology Center. We are bringing you inside information from real conversations we have with patients on a daily basis. We get asked the same questions and want to spread the truth on health and healing because we believe everyone deserves to know the answers.
Hi guys, welcome back to another episode of What Did the Patient Say with myself, Dr. Dana, and my sister, Dr. Lauren Brindisi with Carolina Functional Neurology Center. Today we're bringing you an episode. As you guys know, if you guys have been following us for any period of time, we work a lot with patients that have dysautonomia. And so what we want to do is kind of talk about some of the different types of dysautonomia, because a lot of times people get they either self-diagnose with kind of a blanket statement, or they may just get a blanket diagnosis like, oh, you have dysautonomia from their doctor, and they're not really sure where to go from that, because that's kind of an umbrella term. So today we want to break down some of these subcategories of what these dysautonomias are, so that if you are in the process of kind of figuring that stuff out for you, or if you've had the diagnosis and you're like, is this correct? Like, I feel like I've got other things going on. We just kind of want to touch on all of that. So that's what today's all about. So Dr. Lauren, why don't you give us the breakdown of some of those, initial dysautonomia diagnoses and maybe some of the more popular ones that we hear kind of on a daily basis at this point.
Yeah, so I'll go through a brief overview of the list, and then what we'll do is break down in some very simple detail about how you differentiate these types of diagnoses. And of course, this is just Diagnosis 101. There's so much more that we could talk about in more detail, and newer information coming out all the time. So we're just going to touch on the brief basics for you. So when it comes to dysautonomias, right, that's really just an umbrella term, which just means there's a lot of conditions that fall under that, and there's a lot of overlap in terms of especially symptomatology for these types of conditions. There's a lot of gray area. But when it comes to diagnosing in general in medicine, we try to make this as black and white as possible to say, do you fit in this diagnostic box or do you not fit in this diagnostic box? But the reality is there's overlap for people. But when it comes to dysautonomias, some of the main ones that we frequently see, and I would say are the most common out there, are POTS, which is postural orthostatic tachycardia syndrome. And then we'll touch a little bit on just the different subtypes that we may see. We have inappropriate sinus tachycardia. Those two are big because they definitely can look very, very similar to each other. And there's a lot of overlap. So we'll talk about the key distinction between those two. Then we have orthostatic hypotension. Then we look at the different types of syncope. So somebody can have POTS and not be passing out, not have syncope. They can have POTS and they can have syncope. We kind of look at those as two different things. So we want to break down.
That's a big differentiating factor for people to kind of grasp that concept, because I think a lot of people, and maybe official diagnosis, really think like, oh, well, I'm not passing out, so I don't have dysautonomia, or I'm not passing out, so I don't have POTS. But I think that was like a huge point to kind of hit home, where you can have POTS and you can have syncope, right? So that's a big thing, I think. Definitely. Especially when people are trying to figure things out.
Yeah, for sure. So you can have one of these diagnoses and you can be passing out or you cannot be passing out. That's why we talk about syncope and pre-syncope. So pre-syncope is all those symptoms that come along with these types of dysautonomias, where you feel like you're going to pass out, but hopefully your brain has the right compensatory mechanisms to have you prevent yourself from passing out. However, if you are passing out, we want to look at the different types of categories that fits into. So we look at vasovagal syncope. We look at neurocardiogenic or cardio inhibitory syncope. And then we also look at vasodepressor syncope. And we're going to break those down in a moment here. So Dana, we want to start and talk a little bit about POTS. Can you explain what we're looking at diagnostically when we're assessing a patient to diagnose POTS?
Yeah. So POTS has some pretty specific criteria when you go to be evaluated by your doctor in how you get diagnosed. This is where I do think a lot of people get diagnosed with like a general dysautonomia diagnosis, because I think maybe they may or may not meet the criteria for POTS in these cases. But for POTS specifically, depending on whether you're adult or a child, you need to see a change in your heart rate from supine to standing of 30 points if you're an adult, 40 points as a child. Now, I've seen two different references to age range. So I've seen anywhere like child switches at around 16 years of age. And then I've also seen 19 years of age. So I do think in the literature, maybe there's a little bit of discrepancy on when we would make that shift between 30 and 40 points of heart rate. Do you have a specific? I've just seen a couple different numbers on that one. So I think there's some discrepancy there. But that's the main criteria. So the interesting thing with POTS is most of those patients have a normal or even potentially lower resting heart rate. But when they move against gravity, their heart rate's going up pretty significantly. And then when they stay standing, or if you're on a tilt table and you're at 80 degrees, that heart rate's staying above 100 beats a minute until, you go back into a recumbent position or a lying down position. So those are kind of the big ones with POTS that you have to hit to kind of meet that official diagnosis.
Okay, good. And then the next one that we talked about was inappropriate sinus tachycardia. So the big difference there versus POTS is that your resting heart rate is over 100. So I will say we do see a lot of people come in. Of course, POTS is the most common and it definitely gets the most publicity. So we have a lot of people that come in being diagnosed with POTS, although they may have a different diagnosis. It doesn't necessarily, for some people, change what course of treatment either their cardiologist is going to give them or even us in terms of functional neurologists, because we're really evaluating their nervous system for what it is, not necessarily their diagnosis. But it is important to differentiate, because having a heart rate when you're seated or lying down that's over 100 beats per minute might be a very different neurological mechanism versus somebody who has a heart rate when they're seated or lying down that normalizes or drops lower. There's different aspects of neurological function that might be playing a role there. Any other thoughts on that, Dana?
Yeah, I think the biggest thing and what I see when patients come in who have been diagnosed with POTS but actually have IST is patients who have IST can actually meet the orthostatic criteria for POTS, but in those scenarios, the diagnosis of IST supersedes that POTS diagnosis. So you may have a resting heart rate of 100 or above, which is going to put you into the category of IST, but you still may see a fluctuation in your heart rate of over 40 or 30 beats a minute when you move against gravity or you do your tilt table test. But in terms of ranking those diagnoses, IST would come first in that scenario. So you would actually fall under that category as opposed to POTS, even though you still meet the criteria for POTS. And like Lauren said, the medications don't really change for these conditions. But when we evaluate you as functional neurologists, most of the time, I would say, very commonly, the underlying mechanism neurologically where that dysfunction is in the brain is different, which is important for us. And if you come to see us, obviously we'll know that and we're treating your exam findings, but just so everyone has kind of a clear picture of what that means. I think the next one we're talking about is orthostatic hypotension. Do you want to give the diagnostic criteria for that?
Yeah, so with orthostatic hypotension, we're going to see a pretty rapid drop in the blood pressure. When it comes to orthostatic hypotension, because I have seen some young people diagnosed with that, and that I feel like is just not very common at all. We might see some disparities in the blood pressure when patients go from lying to standing, but it's a very distinct drop in the blood pressure when somebody stands up. And often we see that in more of our elderly population. And there's varying types of degenerative conditions that can actually create that type of orthostatic hypotension. And it usually comes along with other neurological conditions.
Yeah, and it is a 40-point drop in that systolic blood pressure to meet the criteria for orthostatic hypotension. Whereas, like you said, we see patients that have maybe fluctuations in their blood pressure, but they don't quite meet that criteria for orthostatic hypotension. So you might hear that being referred to as orthostatic intolerance, where your blood pressure shouldn't drop when you stand up, right? But if it's not meeting that diagnostic criteria, then you don't have that diagnosis.
Yeah, and that's where orthostatic intolerance is a great example of some of those terms that get used to try to fill in some of this gray area. And we talk about this a lot in our practices. We're looking at these diagnoses, again, that are very black and white, but when it comes to actually treating patients, we're really looking at all the gray. So even if you don't meet these criteria and fit in one of these blanket diagnoses, that doesn't mean you're not having autonomic dysfunction. And that doesn't mean that you couldn't be very symptomatic or even more symptomatic than some people that are hitting these criteria. So keep that in mind. And again, that's
for those people that are being told everything's normal, right? Everything's normal. And we talk a lot about this in reference to POTS when we say, patients are like, I'm sick. I don't feel good. I think I have this dysautonomia. They've got all the symptoms of it, yet maybe their heart rate only goes up 25 beats when they are on their tilt table, like they pass their tilt table test or whatever, but they're still extremely symptomatic. Those are the people that I would say, go find a functional neurologist in your area, because you probably have autonomic dysfunction that needs to be tweaked and changed, and it can make a huge difference for your quality of life, even though you don't meet the criteria for a diagnosis, which in some cases I think is better. I think those patients are the ones that struggle to get help, sort of, because they fall into that gray area.
Yeah. But when you look at it on a spectrum, if you can get the help and it's something mild, hopefully it doesn't lead to something more significant as time goes on. Right. So the next thing that we're going to talk about, again, separate from those diagnoses, would be if you're actually passing out, if you're having syncope, what types of syncope are we dealing with, and how would we know the difference between them? So those three, like I said, were vasovagal syncope. We have neurocardiogenic syncope, also cardio inhibitory syncope, and then we have vasodepressor syncope. So Dana, you want to talk a little bit about the differences in those?
Yep. So we'll just get into real quick kind of nitty gritty when we talk about the objective findings that we're looking at for these types of conditions. So for vasovagal syncope, what we're finding is upon testing, you're having both a drop in your heart rate and your blood pressure. When you have the vasodepressor syncope, similar to orthostatic hypotension, your blood pressure is dropping, but in orthostatic hypotension, you are changing positions and your blood pressure is plummeting immediately. When we run diagnostic testing and we're looking at this, people who have vasovagal syncope, their blood pressure is normal, and then it slowly starts to drop down. Right. So in those patients, they have a little bit more warning, a little bit more time. Whereas those patients with orthostatic hypotension, if they're passing out, they're the ones that are waking up on the floor. Same thing with neurocardiogenic or cardio inhibitory syncope, their heart rate's just dropping. And so they're waking up on the floor, right? So some of you guys might be experiencing these different types of syncope. But again, it's a very umbrella term. It's just syncope. We're passing out, we're losing consciousness. But in order to get the appropriate treatment, whether that treatment is medication, whether you're making nutritional changes, whether you go to see a functional neurologist, right? It's important to understand where is that mechanism of dysfunction in the brain? Like where is that even happening, right? Because they're all not created equal, which means that they all deserve their own one, diagnosis, and two, specific treatment for those types of conditions.
Yeah, I would agree. But also Sometimes that can be difficult to find out because one, you do have to go through a full tilt table test. A lot of times, you may not pass out during the test. So finding out the exact type of syncope that you have can be a little bit challenging, unless it happens right at the time of testing. The big thing is that we know that that system is failing, that you're not able to maintain that adequate amount of blood flow to the point of lights out. And that is very different.
Well, I would say on a functional neurological evaluation though, right? Or if somebody brought us their tilt table test, and even though they maybe didn't pass out on their tilt table test, we would probably see the discrepancy there, right? Like it may not have been great enough in the moment for them to have a syncopal episode, but you're going to see those fluctuations in the vitals too. So it gives us at least some indication into the system, like, I think this is more related to your heart rate than it is to your blood pressure, because you were starting to get that pre-syncope episode, but your blood pressure was maintaining, what we would have expected and things like that.
Yes, of course. And what I was going to say is that it's a very different issue that we're looking at from our perspective, I would say, if someone is passing out versus if they're not passing out. So that's kind of step one, to say, are you passing out or are you not? How significant is the failure in that system? And that gives us a lot of information in the first place, whether we actually have all of the criteria or the ability for somebody to get officially tested and to be able to see those things.
Yeah. And I would say in terms of like ranking, a lot of times those syncope diagnoses are going to supersede other diagnoses, right? Because of how impactful they are, right, to the day-to-day, and complications to it, right? And the things that we think about are like, have you sustained multiple concussions as a result of having syncope episodes, right? Like how many times do we hear like, she got up and we found her on the floor and there was a gash on her head. We think she hit her head on the dresser, kind of thing, right? So then we're looking at, furthering neurological dysfunction as a result of having those syncope episodes. What I find to be kind of the generalized medical treatment for these things is really a steroid. Most of my syncopal patients, if they have it, are being put on things like Florinef, which can be super helpful for patients. And I only touch on this because the conversation that we have is if we can create enough plasticity in the system and we can override those faulty mechanisms, whether it's a heart rate issue, whether it's a blood pressure issue, whether it's both, hopefully we can get somebody to the point where they can speak to their cardiologist or their neurologist and maybe start to taper off of those steroids, because those have other side effects to other things in the body, like your adrenals and stuff like that. So those are always the medications that I'm always like, if we can do this right, my goal would always be to try and help the patient, if it's one of their goals, is to get off that specific medication. But that is usually very common with these syncopal episodes.
Yeah.
Okay,
right.
We've got a few more things. We wanted to break down, we kind of want to go back to the beginning. So those are kind of the main diagnoses. As Lauren touched on, there are some neurodegenerative conditions that kind of fall under these dysautonomia categories that we don't typically see in our office because they're degenerative, and usually these patients are given a timeline in terms of what to expect. But there is that end of the spectrum when we talk about dysautonomia, but we kind of want to bring it back to the beginning, talk about something a little bit more commonly seen, commonly diagnosed. So we talk about POTS, again, kind of as a blanket term, but there are multiple different forms of POTS. So Dr. Lauren, do you want to kind of touch on those forms and just what those things mean compared to just a generalized POTS diagnosis?
Sure. And we're just going to briefly touch on this. I think this is something that we could break down in a little bit more detail at a later.
Yeah.
I'm sorry?
Next podcast coming at you in detail.
Yeah, and then we can even touch on some more progressive information that's really coming out there when we're talking about POTS as a neurological condition. which is really more widely being understood and accepted, which is very, very exciting because that's exactly how we as functional neurologists have been treating this condition for a long time. But when we look at POTS in general, the types that we often see people coming in with in terms of subtypes, we would be looking at neuropathic POTS. We would be looking at hypovolemic POTS, hyperadrenergic. I would say those are the top three. But what we're hearing more in the literature and some of the more progressive information, I would say we could add two other types when we're looking at autoimmune POTS, which there's still a lot of new information coming out about that and not a ton that we know at the moment. And then more of a vestibular type POTS. So I think that would fit in more of the neurological category in terms of what we're actually looking at in the nervous system that could be playing a role in fluctuating somebody's heart rate. And I think that fits in more of our functional neurological category. We could probably break down the type of POTS in a whole bunch of different categories from a central nervous system perspective to say, where is that area of dysfunction actually coming in? And the vestibular system is always on our differential list, because when you actually change position, that requires information coming from your inner ear to tell your brain that you're changing position. And then your autonomic system needs to work in concert with that to make sure that you maintain blood in your head. But if your vestibular system's not telling the right story when you go and stand up, your autonomic system is going to respond to that perception, not what's actually happening. And so what we will see is that heart rates are all over the place. If somebody feels like the room is spinning around them, even though they're lying down, right, their heart rate's going to go up. So we're going to see autonomic type symptoms, even though it may actually be related primarily to their vestibular system. So that says that they could be having autonomic issues, but the primary issue might be living somewhere else.
Yeah. And that, as we've talked about so much, is really our main job, right? Like, where in the brain is that dysfunction coming from? And just because you have the same diagnosis as like 10 other people that walk in the door doesn't mean that you have that same dysfunction. And that's where I think we see a lot of success in the field of functional neurology, is we're able to break that down into its nitty gritty. And I mean, we could go way in depth. Maybe we do a vestibular podcast, right? Like, we could go way in depth to say, like, okay, this is a left anterior canal dysfunction of the vestibular system, right? Which changes things versus saying like, oh, this is a left posterior canal dysfunction of the vestibular system, right? We've got different feeds into the brainstem, right? They hit different nuclei in the brainstem. Like, there's so many different things that go into that. And it's just like, this is where I get all excited, right? And we're like, ooh, which one is it, right? But this is really where functional neurology sets itself apart from other types of therapies that you could get for these types of conditions. So
yeah, definitely.
I have a biased opinion, but I think that's pretty cool.
Yeah, I was going to say, you're getting me excited because now I'm thinking about the cerebellum too, because it's really interesting. Just briefly, really quick, the cerebellum coordinates everything the brain does. So traditionally, especially as in neurology, the history of neurology, as we learned about the cerebellum, we talked a lot about how it coordinated motor movement. But now we know it coordinates everything from your autonomic system to your thoughts, also your motor movement, just everything. So I do see people that I actually will, from a functional neurological perspective, say their primary area of dysfunction is somewhere in their cerebellum, their left cerebellum, right? And that's another one that I feel like we see looks kind of like vestibular, because the autonomic system is not being coordinated properly. So you'll see heart rate and blood pressure all over the place. But you might see some other types of findings too. And that's where our detailed exam comes in to evaluate that and say, what part of the cerebellum is this? Or where is that feeding into other areas? And then how can we drive rehab to actually exercise those brain regions, which is just a very different viewpoint than saying, okay, you have tachycardia. The tachycardia is just a symptom. The next question is why is that happening?
Yeah.
And all these diagnoses are important to understand. And then we can go even nitty gritty into more detail of what that actually looks like for you, which might be different than the next person, just like Dr. Dana said.
Yeah. I always tell people the cerebellum, I think Dr. Carrick probably used this, so I probably stole it from him, but the conductor of the orchestra, right? There's like all the different parts and all of the different players, right? But somebody's got to make sure everybody's working together, and that really is the cerebellum. So that's fine. All right, cool. Well, the pup is ready to go. And I think we're wrapping up here. So as always, hold on one second.
All right. As always, just like, comment, share. If you have any further, more detailed questions, please let us know. We are interested in kind of delving a little bit deeper into these podcasts. I know, especially last year, in the beginning of this year, we've been really just touching on some basics of things. But if there's any specific conditions or other information that you guys really want to know more detail, start getting into some of the science of these things. That's what really gets us excited. So we're of course interested in starting to break that down for you guys too. We definitely think knowledge is power, and the more that we all understand, the better we can help each other and just live and love our lives.
Yeah. So I think we've got 2 more podcasts that we came up with today: vestibular and maybe cerebellar. And then
the types of POTS.
And breaking down the types of POTS, so maybe 3. But stay tuned, because we've got some other podcasts coming up for you guys. We're going to talk in detail about the hypothalamic pituitary thyroid axis, which we talk to a lot of our patients about. And then we're also going to talk about the hypothalamic pituitary adrenal axis, which a lot of you guys deal with thyroid dysfunction. A lot of you guys deal with adrenal dysfunction and adrenal fatigue. So I think those are 2 big ones that we'll have here soon that I think a lot of people will be interested in hearing.
All right. We'll see you soon.
All right.
Have a good day.
Bye.
Bye.